By the end of my orthopedic practice, I was just miserable. And you've been here, right? You're taking call. You don't have any control over your patients, over your lifestyle. I wish I could go back and say that I did it with full consent of my family and that everybody was on board. And that's not true. I jumped ship and burned some bridges, and I had to intentionally. And I was doing what I thought was best for me and for my family. And there were some dark times. The light is there. I can see it at the end of the tunnel, digging out of a hole that I created for myself. What got me through to it was knowing what the mission was, knowing what the purpose was, and understanding that if I treat people the way that I want to be treated, there's really no way that this thing can fail. And so that's what we call it. We call it health optimization because ultimately we can take almost anybody and we can make them feel better.
Okay, good morning, everybody. We've got Dr. Lucas with us today. Dr. Lucas, can you hear me okay?
I can hear you just fine. You and me?
Thank you. I heard a little bit of the preliminary stuff. So anyway, welcome to the podcast here. I'm just going to take a moment to allow you to introduce yourself formally for the folks that aren't aware of who you are. Where by the way, where are you located at, Doug? We're in Asheville, North Carolina. Okay, that's a pretty area. It's real nice. I've been there before. It's had actually a good. My old guy I went to war with, Dr. Tom Large, he had a practice there, orthopedic practice there. So
yeah, I know Tom actually.
Oh, you do? Okay, Tom's a good guy. I think he left, and I can't remember where he's at now. I think he moved somewhere.
He did. He left around the same time when I left. He was on his way out as the whole conversation around the hospital takeover. But yeah, he unfortunately had to leave.
Got it. Let me just start with that. So what do you do out there, and give us a little bit of your background.
Yes, I'm an orthopedic surgeon by training. So I went through the whole traditional medical training, orthopedic surgery residency, fellowship at Stanford, started practice in Colorado and had a traditional orthopedic practice, fixing fragility fractures. I had a foot and ankle subspecialty practice. And through the course of my early practice, I got pretty frustrated, which I think is somewhat common, by the inability of even a great surgery to really have a positive impact on patients. Surgeries would go great, but the outcomes would be questionable. And what I learned is that it really comes down to what are we starting with and where is the patient and their health? And I started having conversations with them about these kinds of topics, nutrition, exercise, lifestyle, and it just fell on deaf ears. And so I started getting frustrated. I started finding that there were lifestyle practices out there. My wife is a PhD in nutrition. And so watching her manage patients and this incredible change that people were having through really carbohydrate restriction is one of her main tools. And so then I started to slowly shift my practice. I moved to Asheville in 2018. That's when her business needed a place to grow. So we moved out of Colorado and started in private practice here. And that's when I met Dr. Large, who was at the hospital system locally. And so I continued to practice there, but it actually got worse because I was at Dr. Large and I were at this very busy level 2, but acted as a level 1 trauma center. And so could do really nothing outside of just take care of patients orthopedically, which was fine, but I feel like not what I was really meant to do. I really wanted to talk to people about lifestyle and nutrition, et cetera. So ended up getting some additional training, going part-time. I got a fellowship through A4M and eventually did some more hormone work with them and then started my own practice. And so left the traditional medical system around the beginning of the pandemic, started a telehealth practice, leveraging the changes in laws around that time, and have continued on since then. And now we're seeing patients in all 50 states. I have 2 branches of my practice. So I have a health optimization practice, which is really just hard to pin down, but health optimization, helping people live better, longer. But then I started a bone health wing, an osteoporosis side, based on people coming to me because of my previous experience in orthopedics, and basically took what we do in the health optimization side, but then just spun it, got different labs, a different approach, but using the same framework to treat osteoporosis and reverse that naturally without drugs for the most part. So that's what we've been doing for the last 3 years, and it's been awesome.
Yeah, well, awesome. We've got a lot of stuff in common then. Certainly as a foot and ankle guy, you would have seen a lot of the impacts of particularly diabetes. I know some guys, that's part of their practice. Some don't do that. But if you do, it's just so obvious how that disease ravages the musculoskeletal system. And I'm sure you were trained similar to me. Nutrition was an afterthought. It really wasn't even a thought. I can't even call it an afterthought because we really didn't focus on that. It's all about mechanics and all about the gee whiz tools you have in your trade. It's cool stuff. When you realize how important the biology is, and it's all the mechanics we do affect the biology, and the biology affects the mechanics. And so the disease stuff is interesting. And you're right. It's really hard to do a lifestyle related practice in the framework for orthopedics. You got like, it's volume, man. It's like turn and burn patients every 15 minutes if you're lucky. Most times it's more than that.
Yeah.
We
were less than that. Yeah.
And sometimes like I got 3 patients slotted in a 15-minute time place.
That's
Time zone is crazy. You're seeing 40, 50, 60 patients a day. And God, it's crazy. So what, I guess you said you had a wife with a PhD in nutrition.
Mm-hmm.
You started to realize that what was the I guess the final straw that said, I can't just do traditional orthopedics. I'm going to get out and branch out and do this other stuff.
So it's funny you mentioned diabetes. Honestly, that was the thing that just kept coming up over and over again. And I remember in Colorado, the first time my wife said, hey, I'm working with this diabetic patient and I reversed their diabetes. And I was like, you can't do that. That's not possible, because we're taught that it is a progressive disease and you will go on and you'll lose limbs and be on insulin and you're going to die. But sure enough, for her, whatever the definition is for reversal, patient's not on any medications and they have a normal A1C. So call that reversal, call that remission, call it whatever you want. So I recognized that, what I could do, like you said, I have some cool tools. I can do orthotics and I can do surgery and I can move the foot around and I can get wounds to heal and I can do all this stuff, but it doesn't change their diabetes. So the straw that broke the camel's back was a night that I was on call at our local trauma center, and we get that 3 a.m. call. And this was a patient, diabetic patient, young guy, 30s, had a wound that was not healing and had an infection, got septic, and had a leg that needed to come off in the middle of the night, right? So this is not an uncommon thing in general orthopedics, and especially not in the foot and ankle space. So I go in and meet the guy, and we're doing this case. And this gentleman, super nice guy, massively obese, probably 400 pounds. And Shawn, putting a 400-pound patient on an operating room table is a challenge, right? Because they're made for, access to all of the body. So it really just covers the spine. And so middle of the night cases, you have a skeleton crew. And so me trying to put a tourniquet on the leg, trying to position this patient on the table, really with no help, like up to my ears and elbows in this guy's thigh at probably 4 a.m. now. And the patient's not doing well. And everybody in the OR is worried that this guy's going to die on the table. And so I got to thinking, what the hell am I doing here? What am I doing this guy any good? Yeah, we're going to take his leg off. And we did. And we saved his life. But really what this guy needed was a conversation probably 20 years ago that you have all the time, that I now have all the time, which is, look, diabetes is a disease of nutrition. This is not a medical problem. It becomes a medical problem, but it's a disease of nutrition. And if you change the way that you eat and ignore what you're being told to eat, then you can actually put this thing in remission, assuming you're a type 2 diabetic. And so I got to meet this guy. And this was one of the times too, when I learned that in training, because we don't have good follow-up with patients in training, we're just exposed to people intermittently, right? In training, I just assumed that all out of control diabetics were just making bad choices, right? Like eating off plan and not following guidelines and not taking their drugs. This guy was one of many examples for me, and the last one in practice, where he was just on it, man. He ate exactly what he was told to eat. He was eating a nearly plant-based lifestyle, a low fat. He was doing all the things that he was told to do and taking his medications and on insulin and getting worse and worse and worse and worse. So that was probably the straw that broke the camel's back. And I was like, I got to do something else. And so fortunately, I was in a place to do that. And all the craziness that happened in the world around 2020 also actually pushed me in that direction and allowed for me to do it.
Yeah, I can totally relate to that story. I can remember a 550-pound gal with a femur fracture. I had to do that in the middle of the night and couldn't do an antegrade rod. We had to go retrograde because it was just impossible to.
You can't get it in there.
You can't get it. You can't find it. You can't even find a greater trochanter on that person. It's just crazy. Yeah, I can see that where that is. And it's something like why I went into orthopedics in the first place is because I was like, I'm going to avoid all this lifestyle related stuff. But ultimately you realize that everything I'm doing is because of the result of a lifetime. I mean, occasionally you get a trauma, occasionally you get an athlete with a sports injury, but most of the time it's just all the arthritis, all the tendinitis, all that stuff is just lifestyle that adds up. And so it's interesting now that you're doing that. So I guess the osteoporosis, because I've now seen several, I think, legitimate clinical reversals of osteoporosis with diet. I think And I think protein is a big, because when I learned about osteoporosis and orthopedics, it was calcium, vitamin D. We didn't really talk much about protein. You know, like about bone is like 45% type 1 collagen protein. And it's just, we're not even talking about that. As orthopedic surgeons, we should know better. So let me just delve into that a little. What do we need? How do we need to treat osteoporosis? What should we be doing?
Yeah, it's a really something that evolved over time, because when I was in practice in Colorado, my PA started this traditional fracture liaison service, which for those that aren't familiar with that, basically it's the good medical way to treat osteoporosis. Somebody comes in either before, preferably, or after a fracture, you evaluate risk, and then you potentially put them on meds and you talk about calcium and vitamin D, right? That's the model. And it's good because that's actually the only model in the traditional medical system that does really anything for people with osteoporosis, because everybody else wants to just turf it to someone else. Nobody wants to own bone health. And so I had that background. And then when I started the health optimization side, we used this framework of lifestyle and then targeted based on biomarker supplementation and then hormone optimization. And we talk about peptides and we talk about drugs if we need to. But by the time we get there in the framework, you pretty much don't need to. And so I looked at osteoporosis through that lens and started doing research and recognizing, man, like if you actually hit all those things, you can reverse osteoporosis, particularly in younger patients. And then everybody's afraid of the drugs, and they should be. And we could talk a lot about that. I think there's a time and a place, but for the most part, they're way overutilized. Nobody wants to take them, and that the side effects are pretty terrible. So there's this massive group of people that really want to improve their bone health on their own. But this is actually why I reached out to you, is that when I got into this space, I recognized that there's the plant-based, vegan, alkaline diet dogma has just permeated this space. And I started talking to patients, and I have a YouTube channel, and I get so many comments on it, probably like between 100 and 200 comments and questions a day. It's unbelievable. And so many of the comments are, I started eating a vegan diet. I started going down this alkaline pathway because I know that I have to alkalize my body to save my bones. And that's a whole debate in and of itself. But what they do inevitably is they reduce protein intake every single time across the board. And they're not getting better. And they wonder, why am I not getting better? And there are a lot of different factors. But the first thing we do when we see patients is to have this conversation, and we have them track their food. How much protein are you getting? And inevitably, it's 30, 40 grams a day. If that, and coming from plant sources, not utilized, not absorbed. And so the first thing we do is to put them on a animal forward, protein forward diet, getting adequate protein, which we have to work them up to because they are so resistant to it. So that's why I wanted to have this conversation with you to say, man, I think eating a carnivore diet is the optimal epitome of how to eat a animal forward, protein forward diet. And then getting this in a comfortable way through the minds of people who have really adopted this alkaline principle over the last, I don't know how many decades. This is the space that I'm in, and I'm looking for any potential benefit that I can to help encourage patients to look down this pathway rather than down the alkaline plant-based pathway.
Yeah, I talked to Stu Phillips a while back. I don't know if he's a big protein guy, protein research, and there was this so-called acid ash hypothesis that we would see hypercalciuria, so calcium would be excreted in the urine with a higher protein diet. And the assumption was because of that was being leached out from the bones, what it turned out, it was basically just your absorption of calcium is better when you eat a high protein diet. So it's just equilibrating. And so that sort of theory has been shown not to be true, although there's still people that buy into it. And I think you get this alkaline bias, these people doing that stuff. And we see now, there's pretty good, I think there's a number of now, you've probably seen in the last 3 or 4 years, probably 3 or 4 large trials have shown increased fracture rates, increased bone fragility, increased osteopenia, osteoporosis in vegans and vegetarians, because I think for that very reason, they're limiting protein, or their protein quality is not as high in many cases. So you can cobble together protein, particularly if you use a lot of isolates, plant-based, where you can get that, and some of the vegan bodybuilders are doing that. But for the most part, it's a pretty bad diet, and for bone health for sure. And so that is one of the many shortcomings of that cell diet. I have to ask you, I'm looking at 2 things there. One, I see a guitar behind you, and I know one of our guys, Bill, will be interested in that. And I also see the shirt. That's not the cow, it's the how, and that's a sort of thing. I'd Sacred Cow is Diana Rogers. I know Diana and Rob Wolf quite well, and so that's something that obviously, if you become an advocate of animal based eating, then you always get the sort of comment about you're destroying the planet and we can't make this sustainable for everybody, which I think is another discussion. But so I guess I would guess within your population of people you're serving, how hard is it to get people to say, hey, I'm going to start eating more, steak or whatever you're telling me to eat? It seems like there's always this sort of, you got to do this kind of reverse brainwashing type of thing. Do you run into that much?
Oh, totally. And I'm going to expose myself right now and tell you what my approach is so that all of my future patients will now know what they're getting themselves into. But yeah, like I said, I see the resistance is there. Once they're on board, though, they are typically, I don't want to use the word desperate, but they're looking for the answer, right? What is it that I'm missing? And when you point this out, especially having them track food, I mean, I can't think of anybody eating a plant-based diet that's come in that is getting adequate protein. And I tell people, look, it's possible, like you said, like you can piecemeal it and put it together and you can use plant sources, but it's so hard. And you're eating a completely processed food diet. And our two big principles are whole food products and animal forward, because it's going to be better absorbed and better utilized. So I say that they recognize the issue and then they are open. I can't think of anybody that stayed completely plant-based working with us. And then once they're on the pathway, you've seen this, right? They feel amazing, right? Then we start doing an elimination diet. We start pulling things out. We pull out grains. We pull out hyper-processed foods. We pull out added sugars. They just start feeling better and better. And then, yeah, we're still working on their bone health. But this goes back to the health optimization side, which is their energy's better, their sleep is better, right? Like everything just starts clicking. And so once they start seeing that, then they're all on board and they would do whatever, which is just such a wonderful place to be in. But I'll give you an example. I just had this conversation with a patient, a couple actually. They wanted to start working with us, and the guy they're both optimization patients, but the gentleman wanted to just up level, and he works with another company right now, and he's looking for more options. He wants to be more creative, and I love that. That's my bread and butter in the health optimization side. But his wife, and I love, you've probably seen this. I love this story because it's powerful. So she is a Crohn's patient. So she has really bad Crohn's disease. And they were asking me questions about my approach. And she is to the point where she's on a biologic drug. She is getting worse. They're talking about surgery, start chopping stuff out. And she said, what's your approach? And I said, I'm going to start with an elimination diet. And I've had the most success with putting patients on a full carnivore diet to see what kind of reduction in inflammation we can get. And the guy laughed and he looked at his wife and she looked at me and with this look on her face of, how do you know that it's okay for me to eat beef? And I said, I think beef is the right thing for every human to eat under pretty much any circumstance, full stop. I don't have to do any testing to tell you that. And the look on her face, it just went against so much dogma that she had been taught and that she had been listening to and reading. And I don't know if she'll start with us because she wanted to meet with our head nutritionist and she just has so much doubt. If she starts with us, though, I have no doubt that we'll be able to at least make a significant impact in her IBD. I can't say that we can reverse Crohn's all the time, but we have had success with it. But starting with that, it is just so powerful for them to get away from all the inflammation of the vegetables and the fruit and whatever's bothering their gut. And I have not seen anybody not tolerate a carnivore diet.
Yeah, in fact, the other day in this little group here, we have a fellow, I'm not sure if he's in here now, has 20-year Crohn's, 5 surgeries, 2 bowel resections, and he had a bunch of obstructions and adhesions he had a surgery on.
Right.
Was on Stelara, which I think he was saying it was something like $40,000 in an infusion, which is just ungodly ridiculous.
Yeah.
And went carnivore, I think, back in January, and he's off everything, completely asymptomatic. First time in his life after 20 years of having that. You think about, particularly if you catch this stuff early, you can avoid all that nightmare, bowel resections, just horrible quality of life, all the drugs, all the biologics and all that stuff. And so let me ask you, because orthopedics is a pretty good line of business. You go in there, it's obviously you got to get in orthopedics, you got to bust your ass in medical school, you got to graduate near the top of the class. You got to do all that stuff, and then you get there, and then you can make a pretty decent living at that, and then saying, I'm not going to do that anymore. I'm going to go this other route. How were you nervous about that, or was it something that was like, I don't know, man, what's going to happen? And I guess now that you're a couple of years into it, are you happy you made that decision? Was quality of life better? Talk to me about that part.
Yeah, this is an interesting thing. By the end of my orthopedic practice, I was just miserable. And you've been here, right? You're taking call. You don't have any control over your patients, over your lifestyle. I have 3 young kids. I have 11, 9, and 4. My wife runs a business, like I said, and what my family needed from me was predictability, presence, and time. And I couldn't provide that. And I hated it. And there wasn't the political environment of the medical system here in Asheville. It was either you do this thing or you don't practice here. And so I actually did. I left and I was practicing an hour and a half away outside of my non-compete for a while, but just unhappy across the board. And so I knew that I liked this other approach to medicine. My wife's business was increasing in size. So she sees somewhere between 4,000 and 5,000 people a year through her practice. She has 90 employees and just crushing the weight loss space, serving a ton of people. And I saw this opportunity where patients were coming out of her practice and they were not being able to find what they needed, whether it be hormone, thyroid, whatever. They were not being supported the way they needed to be supported. So I thought, man, what if I started this thing and I could just practice the way that I want to practice and then just see what happens? That was a challenge because my wife didn't like the idea of us losing that security and income. We're like, it's a good paying job and it is stable. I can always find a job. And so that was a really tough time. It was a tough time for our marriage. It was a tough time for me personally because I felt like I was betraying my family and what I had told them I would do versus what I really needed. And I wish I could go back and say that I did it with full consent of my family and that everybody was on board. And that's not true. I jumped ship and burned some bridges, and I had to intentionally. And I was doing what I thought was best for me and for my family. And there were some dark times. A couple of years I didn't make money for almost 2 years. It was a loss. Building it up, generating the patient base and figuring out how to market for a telehealth practice with no sign, no doors, no referral pattern, and learned a whole lot of skills around being an entrepreneur that you don't learn in medical school. So yeah, it's been a really challenging road, but now on the other side of it, especially with the YouTube channel, my practice is essentially saturated. We're still onboarding patients, but not many because the way that we treat people, they want to stay on board. I have a PA. She's going to start seeing patients soon. We're offering some avenues that are lower cost for people that want to see the style, but not necessarily work with us in our full service program. So we're in a good place now, building the team, and the light is there. I can see it at the end of the tunnel, digging out of a hole that I created for myself. But what got me through to it was knowing what the mission was, knowing what the purpose was, and understanding that if I treat people the way that I want to be treated as a patient, and I'm using all the tools that I have, there's really no way that this thing can fail. And I just had to keep that, do a ton of work on myself in this process. And honestly, it's been the best thing that I've ever done because getting to be an orthopedic surgeon was a goal. And yeah, we had to crush it to get there and to be the first DO surgeon in Stanford and publishing and doing all these things you don't do as a DO. That was great, but I was miserable. I was successful, but miserable. So now I am fulfilled and arguably make less money, but ultimately my lifestyle is better. I see all my kids every day, drive them into school on certain days. My kids want me here. I'm the first person that they want to see when they come home, and they know exactly where I am. And there's a lot to be said for that.
It's funny. I went down and visited another orthopedic guy down in Louisiana, and he was transitioning from his orthopedic practice to more of a lifestyle type practice. And he was actually saying, I was literally like happy when cases canceled because I go to my other clinic and have fun, because he was the same thing. It was like, it was more fun to do the lifestyle stuff because you got, I think, a better result ultimately. And then totally. It's just, the surgery can be, it's fun to operate on. I had a blast in the OR, but it can be, the results are not what you want. They can be a grind. And it's just like I told people, I would sit there and you replace somebody's knee and they have a good outcome and they come back to you a year later for their other knee and you pat yourself on the back because you thought, but really you should have avoided that other knee replacement. And you could have probably. Right. And that's the thing. I think a lot of people, I was shocked when I started putting people on diets, and people that I would have otherwise brought to the OR were getting better. They're like asymptomatic now. I'm like, this is very unusual. And I'm sure you're probably seeing that as well now. Wow, joint pain goes away when you fix the diet. That's not a concept that orthopedic surgeons are really familiar with, I don't think. Correct me if I'm wrong, but are you seeing the same sort of things?
Yeah, absolutely. And it's funny, people are attracted to me in the health optimization space because of my background. And same thing with the bone health thing. They're like, oh, you understand bone. I guess that's true. But I wasn't taught anything about bone health as a surgeon. I was taught this is how we put plates and screws and nails and bones. But yeah, so now people are coming to me and I will do all the work that we do. And then that knee replacement that was scheduled, they just keep pushing it back and then they cancel it. And it's that there's so much to be said about reducing inflammation, improving your lifestyle, improving your circadian rhythm, improving your sleep. And you start checking off all these foundational things, and it's amazing what gets better. And I'm not saying I can fix everything. I wouldn't make that claim, but you can make so many things so much better.
Yeah, absolutely. It's what actually being a doctor is supposed to be about, I think. I think it's evolved into this symptom management, even joint replacements. I consider them expensive Band-Aids because the arthritis is still there. You've resurfaced the bone, but soft tissue still has arthritis. The other joints have arthritis. It's still in the body. You haven't gotten rid of it.
You've kind of inflamed. Yeah, man.
You've put a Band-Aid on that. And if you start looking at some of the pain literature, and you look at the orthopedic literature, and everything's sunshine and rainbows, and you look at the pain literature, and wait, a lot of these joint patients still have pain. It's because their synovium still hurts, and all the soft tissue around there from the chronic inflammation is there. Tell me a little bit, so the health optimization part of it, what is that? I guess before you do that, did you have a personal transition in your own health? Did you at some point say, I'm going to clean up my diet and change things and have a personal relationship? Because I did. I certainly was. That's what propelled me to do this, because I was mid-40s, and I was like, I've been an athlete my whole life, but I don't feel that good. And so I started playing with diet. It took me about 7 years to come into this crazy carnivore stuff. But on my way there, I started noticing that and then wanted to apply it to the patient. So did you have your own personal journey?
Yeah, I don't have a deep bottom where I was 100 pounds overweight and diabetic. But my background, my parents are both really heavy, and my dad is over 300 pounds and pre-diabetic, and my sister is over 300 pounds. And so my genetics and predisposition to be obese are really high. I was always an athlete of some kind doing one thing or another. So that kept me relatively fit. But as most people going through medical school and residency, that sort of deteriorated, and you're young enough or you're tolerant to it. But when you start getting into practice and the late nights and the circadian rhythm effects and eating the fake peanut butter and saltine crackers and the doctor's lounge, that stuff catches up with you. So yeah, I did. I got up to, I think my highest was probably 240, and I'm 6'1"-ish, a leanish frame. So for me, that was carrying an unhealthy amount of weight, visceral fat, and just felt terrible. Yeah, I had that inflammation and pain and everything hurt, and I wasn't able to do the things that I wanted to do. And working with my wife, like I mentioned, her approach is behavior and really carbohydrate reduction, finding your carbohydrate tolerance level. And I don't think in her program she's ever put somebody on a completely carnivore diet, but that approach will push people into it because they find it and they're like, I like eating this thing and I feel good when I do this. And so I've gone down that pathway. I've spent periods of my time eating a purely strict carnivore diet, and I feel really good in that space. I get away from it again because this is an excuse, but my wife loves to cook. I like to eat her cooking, and I'm in probably the best shape of my life right now and can tolerate some of that. I still don't eat a lot of plants. I eat a little bit of fruit. I eat dairy. And I'm in a place now where at 45, I am definitely the strongest I've ever been. And I just had surgery 2 months ago, and I'm still the strongest I've ever been. I feel the best. I have the most energy, the most vitality. So for me, this is a pretty big turnaround, but I wish I had some great before and after pictures, but you can't really objectify that feeling of vitality and energy and drive.
Yeah, so I recently visited my mom in Houston, Texas, and I was thankful she kept some old pictures of me when I was at my probably heaviest, and I didn't even know those existed. I was like, awesome. So normally you want to grab the pictures where you look good. And I was like, let me get all these pictures where I look like garbage so I can use them as before and after. So that was fun. But so the health optimization side. So what does that mean? Or what are we accomplishing there? This was my business failure starting this practice, which is, I don't know what to call this thing. And the concept was, like I said, I'm going to take patients, really focusing on people who are interested in weight maintenance, people that have worked with my wife. And a lot of times they'll come out on the backside, and for men, their testosterone's low. Thyroid generally gets dysfunctional in obesity. Interesting, when you lose weight, it doesn't really get better, it stays dysfunctional. And capturing those patients who aren't really feeling and functioning their best, and then helping them to optimize. So I did a functional medicine fellowship to help with that, but I don't really love medicine because I think it's a dirty word, because anybody can do a weekend course and be a functional doctor, right? And then integrative doesn't really jive, because integrative can mean anything. You can have a therapy dog in your office and be an integrative doctor. So I couldn't really find, what do we do? And I kept coming back to this thing. We're optimizing people's health. We're taking them from where the traditional medical system drops them off and where they want to be. We're bridging that gap. And so that's what we call it. We call it a health optimization, because ultimately we can take
almost anybody and we can make them feel better. Of course, I have the groups that I tend to work with a lot of doctors, CEOs, driven people that have high expectations. But I couldn't market that. Really struggled to find a way to market that. And so the bone health thing has really helped me because it is a clear search term, right? Like I can SEO this thing and created the YouTube channel specifically around bone health, and that's taken off. And so what that has done though, is that once people see the way that we manage patients in our framework, now they want to work with us on the health optimization side. And so we're still building both sides of the practice about equally, but we're not marketing the health optimization side at all. But ultimately, we use this framework, like I mentioned, where it's lifestyle driven. We bring people in a membership style. They're working with coaches. They have access to, concierge ordering. We basically make it as easy as possible to be as healthy as possible. We're ordering labs every 6 months. We have access to functional testing, gut testing. We can do all these things. And then we're setting up a program that is functional and the foundation based. So exercise, nutrition, diet, and connection or spiritual health, depending on what you want to call it. And then we talk about targeted supplements based off of biomarkers, and then hormone optimization or replacement, peptides, and again, drugs at the top, which we pretty much never use. So that role and that style of healthcare can really impact everybody from that Crohn's patient I mentioned earlier to somebody like myself who is feeling really good, but yet my biomarkers don't always jive, right? So what can I improve on? What am I missing? And I'm still working on myself. Like my labs aren't perfect. And so still trying to figure out some of these like really nuanced things that nobody talks about.
Yeah, I don't know that you can ever figure out perfect labs just for a number of reasons. But let me ask you about with regard to, say, let's start with bone health, protein resistance training. You mentioned the drugs, typically the bisphosphonates were the ones, osteonecrosis of the jaw, and you get the weird femur fractures. I know I treated a few of those.
Yeah,
and so those things, you get these weird looking, that's just like I read about in the journal. That's one of these fractures. But if somebody comes into you, osteopenic, osteoporotic, what do you do? What happens?
Yeah. So we use I coined this framework called the 4R method. And I did this again, just to help people to understand how we're different than just throwing drugs and calcium and vitamin D. And the thing about osteoporosis that I think most people are missing is that we really shouldn't be losing bone as we age. Like maybe you could accept a subtle amount of bone loss, but if you maintain your muscle mass, if you maintain all of your biomarkers through the lens of health span, like you shouldn't see precipitous bone loss. So when somebody's losing bone rapidly, we should probably be asking the question of why. So the first R in the 4R method is recognize why you're losing bone. And for a lot of perimenopausal, postmenopausal women, loss of estrogen is obviously the thing, but we find that it's usually more than that. And whether it was a bad starting point or the addition of thyroid dysfunction, inflammation, stress, gut dysfunction, poor diet, et cetera, recognizing which of these variables are in play. And then the second R is to reverse those causes of bone loss. So then we're just making a plan based off of that kind of pyramid I talked about before to reverse those causes of bone loss. And then we want to retest to make sure we're headed in the right direction. Another big failure I see is patients will say, I'm just going to take these 5 supplements that I read about online and I'm going to not take the drugs and I'm just going to do this thing for the rest of my life. But they never retest anything. I don't know that it's working. And a lot of times it's not. So you really, if you're doing it on your own, you got to retest to make sure that it's working. And then ultimately the last 4 of the R's that I love is to revive your life. So there's so much fear and anxiety around this diagnosis of I have osteoporosis. Am I going to fracture? Can I go do this thing? Can I live my life the way that I want to live? And I want the answer to be, look, yeah, you have this thing, but you are treating this thing and your bone quality is getting better. And maybe there are some things you shouldn't do, but for the most part, you don't have to avoid doing these things that you're worried about. So we can revive our life and live without the fear of fracture.
How old are the patients are you seeing? Are you seeing 80-year-olds and stuff like that? Because I can remember doing hip fractures on little old ladies, and literally it was like operating on cornbred, man. You take a hip fracture call and just put a screw in there. It's like you get an air ball. So like there's nothing there. So
did I miss the femur? No, it's in there. Okay. Wow. Yeah, our target population really is starting around 45. So I want to start working with women and men in their mid 40s who are getting an early diagnosis because we have the longest runway at that point, right? So we're like 45 to 65 patients that have the ability to have a conversation around hormone replacement, talk them through the risks and benefits of those things. They have more of a capacity to put on muscle mass, to change their diet, and these things to have a greater impact. So we can do more faster in that age group. Now, I have plenty of patients in their 60s and 70s. I don't know if I have any 80-year-olds. I know I don't have any 90-year-olds right now. And the challenge is there's just less that we can do. They don't have the capacity to do as much resistance training. The other medical comorbidities start to get in the way. But what I like to point out is, look, if you want to avoid being in that group, you need to start now if you're in your 40s and 50s, because now there's just so much we can do. Now is the time to actually start doing these things.
Yeah, I'm into that. And like I said, the best time was yesterday, but if not, then start today.
How about today? Yeah.
And unfortunately, we're seeing younger and younger, all these comorbidities adding up. And like you said, 30-year-olds where you're chopping their legs off because their diabetes is out of control. And
right.
I don't know, I can't even count how many legs I chopped off over the years. With Tom in Afghanistan, or more commonly the vascular pass and the diabetics and stuff. I'm sure you did your share of those too as a foot and ankle guy, probably quite a few.
Oh, yeah.
What, as far as the optimization side, what are the goals you're trying to achieve there? Obviously, I'm a big fan of lean body mass. I think that's a huge, incredibly important just marker of health. But is that something you're focused toward, or what are your major goals, your targets?
Yeah, so I would call that sort of like it's a secondary goal. It's actually a primary goal, but it's something that's hard to, again, objectify. And people don't usually come in saying, I want to improve my lean mass. They might say, I want to look better, but people will come in and say, I can't get through. And you've probably seen this a lot in your colleagues too, because I have, and this is part of the group that I work with, is for me, it's like the surgeons who are like, man, I can't get through my OR day anymore. When I get to my last case, I am dragging. I'm struggling. I don't have the energy. And so that's one example. My CEO, like the hard drivers that have multiple companies, these guys and gals that, the same thing. They just don't have the energy, or by the time they get home, they have no libido and their relationships are falling apart. And they're like, God, I need help. And so we take that thing, we say, all right, let's break it down. Like what is actually wrong? And it's like the same framework we do for bone health. We just I don't have a cool framework to call it anything specifically, but we look at the foundation. What's wrong from a lifestyle perspective? How's your sleep? What's your circadian rhythm? And start breaking those things down. And then when we start focusing on the objective stuff, we're looking at biomarkers in blood. And then we're also looking at try to get everybody to get a DEXA. And we're looking at things like, what's your lean mass? What's your visceral fat content? And then we start setting some goals based off of those things. So we end up treating based off of those things, but people don't come in saying, hey, I want to improve this thing. Rarely, anyway.
What, just back to the DEXAs, how long does it take to reverse osteopenia in your experience? What is it, a year? Is it 3 months? Is it 5 years?
Yeah, so we enroll people for a year because I need at least that much runway. I need at least that much time to start making improvements. Now, the biomarkers we use, there's some cool biomarkers on osteoclast function and osteoblast function that you see improve within weeks to months. So we can tell that we're making an impact. But to see benefits in bone mineral density, BMD on DEXA, arguably, it should be a year, maybe even 2 years, but I'm getting patients that are repeating their DEXA at a year and they're seeing 10, 15% improvement on bone mineral density. So it can happen that fast. I've seen people repeat it. There's an ultrasound study called REMS that give you a T-score as well. And I've seen people at 6 months see pretty significant improvements. So it can happen more quickly. I don't like to push that and tell people that we can do it that fast though. So I would say a year to 2 years is probably what you're looking at.
Yeah, is there any, I know there's like companies like Osteostrong, John Jacobs, who I know has developed something like that, and it's just sort of pressure vibration type stuff. I know there's data out there showing that jumping actually is very good. If you can tolerate, that's quite stimulating to bone. What do you do on the resistance side? Obviously, there's a nutritional optimization, but on the resistance side or the strengthening side, how does that work?
Yeah, so we were initially really deficient in this because I had a hard time getting comfortable with what I could do through a telehealth platform, feeling like, for patients that are at risk of fracture, we should probably have them work with somebody in person. But over time, we found a couple of different things. So we found one option that was a sort of Pilates-based, easy, that I felt comfortable that honestly everybody could do. And that we kind of enrolled patients in that, and that became part of the program. And that was okay, but it's not enough. It's something, but it's not enough. So then I started working with a PhD in exercise physiology who was comfortable working with people and looking at form and putting them on a path of progressive resistance increases over time and progressive overload. And so we've been doing that more recently, started about 3 months ago. So that's been great because now we can reproduce what the successful people were doing with trainers at home. But that's still just resistance, but it is resistance training, which has a benefit. But as John Jakewish's research and Osteostrong research would suggest, you really need more. So I actually just interviewed him recently and have some of his content up on my YouTube channel. And, if you listen to him, he'll say that you need to produce greater than 4.2 multiples of body weight to impact bone mineralization. And maybe you can. I can't do that through resistance training. And so to get that, you really need impact, which is what there's some studies showing jumping off of boxes or chairs or whatever. But I'm not really comfortable telling my patients with osteoporosis to jump off of stuff. So OsteoStrong then becomes a really good modality if they have access to it because it's controlled, it's relatively safe. Yeah, sure, fractures have occurred, but that's just because you're pushing them as far as you can push them. And so I think those things are great, and we encourage people to use those things if it's appropriate, but we are getting them on the resistance pathway, because most of these patients have let that go over time. I see this typical and predictable process where people used to do resistance training, but now I walk my dogs, and now I, whatever, do the things that are comfortable that don't bother them. And so it's much, much better for us to put them on this pathway of resistance training. And then we can add the other modalities. You mentioned vibration. So like whole body vibrations, another one, these things that people can do, but the resistance is probably enough when you have all the other stuff dialed in as well.
Yeah, that's the point you make about a lot of people, because as you get older, injured, diseased, inflamed, your desire and ability to do significant resistance training is really compromised, because you think, let's go out there and do some deadlifts and squats, and they hurt. They're in too much damn pain to do that. So it's not fun for them. So they're not going to be able to do it. So they get progressively limited in what they're able to do. And so when you can reverse that through nutrition, lifestyle, other factors, and then you can open up more things that they're able to do. Do you find that, what about PPIs, proton pump inhibitors?
Yeah.
How many people do you see that as in their history quite a bit? Because these things are supposed to be you're supposed to take them for 2 weeks, and people are taking them for 20 years. What's been your experience with that stuff?
Yeah, this is an interesting area of controversy. And when I finally looked into the research on this, I found this really funny thing, which is the research supports the physician statement, which I hear most commonly, which is PPIs don't impact bone. I just hear it all the time. My doctor said that PPIs don't impact bone. And what's interesting is that if you look at the literature on PIs, bone mineral density actually doesn't really go down, but fracture risk does go up. And so this is a really good example where we are more than our bone mineral density, and fractures occur not necessarily because of poor mineralization, but like you said earlier, they're 50% protein, right? And you're not going to pick that up on DEXA. And so PPIs will have an impact on the morphology of the bone, on the trabecular bone, but not necessarily on the density itself. And so we see it all the time where patients are coming in, they're like, oh, my doctor said this wasn't a problem. And we work our magic to get them off of it. And it's usually working on gut dysfunction and slow motility and low stomach acid. Most people on PPIs don't need to be on PPIs. Change the diet, improve gut function, and we can get most people off of it, with the exception of, I still have this hesitation for people that have Barrett's, because I just don't want somebody to get esophageal cancer. So I think there is probably a time and a place for a PPI, and that's something that we can work around if needed. But for the most part, we can get people off of it.
Yeah, you think about the proton pump inhibitors inhibiting our ability to produce gastric acid, and therefore probably compromising significantly in our protein absorption, because that's the whole one of the rationales why we have it in the first place. And so you got this situation where they're probably not tolerating as much or absorbing much protein, so that's going to have an impact on like you mentioned, the bone being significantly protein, which again, it's amazing. I can even as I dig through my old orthopedic books trying to look at any kind of discussion on that, and at the best it talks about calcium and vitamin D, but it doesn't really mention protein quality, which is shocking to me, because we've got about 10 minutes left. Let me just ask you, first of all, how do people get a hold of you if they want to? I think you mentioned you have a YouTube channel, so I want you to talk a little bit about that. When it's gotten to the day and age where social media it's a two-edged sword. You need it, but it can also be a time suck and a frustrating type of thing. So tell me a little bit about why you started that. Was it just to get the message out, or was it to help to let people know what you're doing?
Yeah. So when we were creating the company, I struggled with the idea of social media, because I'm just not a social media guy. Like I don't really consume it. I find it to be a distraction and an addiction, and I just don't want to be a big part of it. However, it is such a good way to disseminate information. And so I've just adopted it. I understand that I need to play a role, and my team helps me. So we create content together. The YouTube channel was really an attempt to talk to a broader population. So our mission is two-pronged. We want to provide incredible service to our patients and provide for them what they wish they had in the traditional medical system. And that's one part of our mission. But the other side of our mission is to educate patients globally. And that's where YouTube is just remarkable. And when we look at our audience, we are 60% US, but that means that we're 40% global. And it's amazing, the comments and the questions that I get from other countries that don't have the resources that the US has. And so the YouTube channel was really designed around just serving that mission of educating people globally about all of the different tools that are available that are free that you can use to improve bone health and health optimization overall. And it's, like I said, it's really caught on. I wouldn't say that we're like a viral thing or anything because it's a small group. But I think we're adding about 4,000 or 5,000 subscribers a month, which for me is pretty good. I think we hit a peak of almost 400,000 views in a month earlier this month. So like we're definitely speaking to a bigger audience and really happy about that. Out of that, we offer a free masterclass. So it's me talking about once every 2 weeks about, again, these topics of things that you can do. And we talk a little bit more about hormone replacement and we talk about different peptides and stuff. And not that I'm telling people what to do, just exposing them to, hey, look, all these things exist. And that thing, we're a couple of weeks late on this next one, but I think we'll have over 2,000 people registered for the next one, which gives you an idea of what the response has been. Yeah, so we're doing all of that. I wrote a book recently. You can see it over my shoulder. Sorry, it's really small. That wall's far away. So I wrote a book on the same stuff, right? This is a book we're basically putting out at cost. It's on Amazon and it's called the Osteoporosis Breakthrough, the natural way to reverse causes of bone loss and build strong bone. And it's just the same stuff, right? Let's talk about medications and where they probably are indicated and where they're probably not indicated and why maybe you might want to try a different approach first. Let's talk about diet. I basically go through the whole pH thing, just like ad nauseum in there. And I bring up those studies, like you mentioned, that, if the pH thing were true, why do vegan and vegetarian diets result in a higher fracture risk? And so we just go through all that stuff in the book. It's a short read, about 150 pages. And so we're just trying to get all this stuff out there to help to serve that mission of educating patients. And like you said, it is a time suck. I spend about half of my week on content creation and organizing all the team members that it takes to do that.
Yeah, I definitely feel your pain in that, although it's fun to do in a way. What do you still interact much with the local orthopedic community? And if so, are they like, you're nutty, or do they any response with those guys? Or do you have a lot of pushback from other community physicians, particularly, oh my God, you're recommending people eat meat, how dare you, that type of stuff?
Yeah. So Asheville is it's a pretty vegan friendly area. And yeah, when I walk around with this shirt on in Asheville, I get some really interesting looks because it takes them a minute to process it. But in general, in the orthopedic community, I actually worked for a while. I hired a team member to help me to create a program where I could almost get into their practices, especially those that had fracture liaison services, and offer this to their patients, trying to find a way that we could work together to continue to help spread this message. And I would say that the response was, yes, this is definitely needed. But when you start talking to a private or especially a hospital-owned practice about changing the way that they practice, the answer is crickets. They just are, and this is not a slight on them, but they are so focused on doing surgery. We're lucky if they have a PA that they're employing to do traditional E&M coded fracture visits because you just don't make money on it. And that whole attempt and project failed and ended up having to let that team member go because we just couldn't get any traction. So what I've learned is that the docs are interested and they'll tell their patients about it, but they're not going to push people that way. And to be fair, our services we are a cash-based system. So most of their patients are not going to be able to participate in what we offer. Now, we're also launching a self-guided program at a much, much lower price point that'll give them a lot of what we do. But our full service program is cash-based. And when you have a team like ours, it's expensive to run. So our prices are not what our Medicare patients would hope them to be. We just can't do that. So the response has been good. They like what we're doing, but they don't support it strongly. And that's why, again, we switched and pivoted around to just focusing directly on consumer content information. And then out of that, the people that want our services will come out of that. But it's such a small percentage of our audience that I can't say that's why we do it. But we're out there, again, just to get this message out and talking to people like yourselves. John Jaquish was a really fun conversation to have. And I would love to continue to have some of these other conversations with people that are in this space. Rob Wolf and Diana, you mentioned. I just continue to encourage people to look at this as the pathway for health optimization and bone health.
Yeah, it's certainly, if you if you start taking away surgery from a hospital, they don't like it at all, because that literally keeps the lights on and pays for some of the other services that don't tend to make as much money. So they're all in for doing as many surgeries as possible. So yeah, I learned that the hard way several years ago. What's the name of the YouTube channel? Because we got to have to wrap up here in just a second. But
yeah, sure. Yeah. So actually Jeff put it in here. Thanks for that, Jeff. But yeah, it's called Optimal Bone Health with Dr. Doug. And the reason why we did that is I will have a podcast that's launching, but more on the health optimization side. So a little bit broader audience. And that'll be eventually the Dr. Doug Show. That channel exists, but there's no content on it yet. We start recording that next week, and we're super excited about that. The website too, if you want to check out, we have a lot of free resources there too. The website is optimalbonehealth.com for the bone health side, and then optimalhumanhealth.com for the human health side.
Wonderful. That's so awesome. It's good to have yet another orthopedic colleague in this fight, because I think it's going to take a lot of us. And I honestly think I see a lot of frustration in medicine in general. The last couple of years have certainly exacerbated that for various reasons. And I think a lot of people are getting burnt out and fed up, and the writing's on the wall for a lot of folks. So I think this is going to be, you're going to see more and more what you do and I do becoming more and more the norm, and unless the sort of the renegades as we are now. But anyway, Doug, I appreciate it, man. If there's anything I can do, let me know. I'm happy to help. And like I said, if you want to guest on your podcast, I'm always happy to chat with somebody, because you speak more or less the same language from the orthopedic side. So good for you, and keep up the good work. And the rest of the folks, thanks everybody. We'll be back tomorrow. All right. Appreciate it, Doug. Appreciate it, man.
Thanks, everybody.
Bye, guys.